All right, let's talk about an organism that every clinical microbiology lab knows well, Streptococcus gordonii. Now, while it's a common isolate, it brings some really unique challenges. It lives right at that crossroads between being a harmless bug in your mouth and causing life-threatening disease. In this explainer, we're going to break down why this bacterium is so important.
This quote just nails it, right? Streptococcus gordonii is the perfect example of a Dr. Jekyll and Mr. Hyde microbe. In its natural home, the mouth, it can be totally harmless, even helpful. But the second it gets into the bloodstream, it completely transforms into this really dangerous pathogen. And that dual nature, that's the central theme we're going to explore. Just so you know where all this information is coming from, this explainer is built on a comprehensive monograph that we put together using a Gemini deep search. It pulled together data from tons of peer-reviewed studies. So for anyone who wants to really get into the weeds and see the primary literature, the full notebook with all the sources is available for you to check out.
Okay, let's really unpack that dual role. How in the world does a bug that's a key part of our oral microbiome turn into a major cause of infective endocarditis?
So this is what's so fascinating. The bacterium's tools for survival get completely repurposed for attack. In the mouth, Streptococcus gordonii is a pioneer colonizer, helping build that biofilm we all know as plaque. It can even be a good guy, producing hydrogen peroxide that keeps the more infamous cavity causer, Streptococcus mutans, in check. But let's say after a dental procedure, it slips into the bloodstream. It then uses those very same adhesion proteins it uses to stick to teeth to instead grab onto platelets and damaged heart valves, kicking off a cascade that can lead to a deadly infection.
And this brings us right to the main event for us in the lab. When this organism pops up in a blood culture, getting the ID right isn't just an academic exercise, it has huge clinical implications.
You know the drill. On the bench, the initial workup seems pretty straightforward. We see gram-positive cocci, usually in pairs and chains. On blood agar, you get those classic small alpha hemolytic colonies. And the key biochemicals? All negative. Catalase negative, PYR negative, and it's optogen resistant, so you can rule out Streptococcus pneumonia. But this is exactly where the trouble starts.
As this table makes painfully clear, the standard biochemical profile for Streptococcus gordonii is pretty much identical to its close cousins in the Streptococcus mitis and oralis groups. They're all alpha hemolytic, catalase negative, and optogen resistant. This overlap means traditional methods, and yeah, even some of our automated systems, just can't reliably tell them apart. They often get lumped into a generic mitis group.
And this chart shows exactly why that lack of specificity is so dangerous. Just look at the difference in risk. If a patient has bacteremia with the Streptococcus mitis or oralis group, the risk of having infective endocarditis is around 19%. But if that isolate is actually Streptococcus gordonii, that risk skyrockets to over 44%. That is more than double the risk. Nailing the species can literally be the difference in a doctor ordering an urgent echo or not. So the bottom line is, speciation matters. A lot.
So, how do we solve this puzzle? We have to move past the classic biochem. MALDI-TOF is a total game changer for speed, for sure. But with this group, you have to be careful with lower confidence scores. For a definitive answer, you've really got to go molecular. Standard 16S sequencing can struggle here, but looking at the more variable 16S, 23S spacer region can help. And for the absolute best resolution, sequencing housekeeping genes like ARPO-B gives you the discriminatory power you need to confidently tell these species apart.
Now that we've established just how critical identification is, let's zero in on the #1 clinical threat from Streptococcus gordonii, infective endocarditis. The way this disease develops follows a classic and really devastating sequence of events. It usually starts with a temporary bacteremia, often from something happening in the mouth. The bacteria then use their surface proteins to latch onto damaged or prosthetic heart valves. Once they're anchored, they start building a biofilm, a vegetation, that acts like a fortress, shielding them from the immune system and from antibiotics. And from that fortress, little pieces can break off, travel through the bloodstream, and cause strokes, infarcts, and all sorts of other major problems.
Treating this infection is a serious business. It means long courses of high-dose antibiotics. So let's take a look at how the different international guidelines tackle this.
Okay, so for native valve endocarditis, there's actually a really strong consensus across the major guidelines, from the Dutch SWAB, the European ESC, and the American IDSA-AHA. If you have a fully susceptible isolate with a penicillin MIC of 0.125 or less, a 4-week course of penicillin or ceftriaxone is the standard of care.
Now, if that MIC creeps up a little, they all agree. Add 2 weeks of gentamicin for that synergistic punch.
When you're dealing with a prosthetic valve, the treatment gets longer, a standard 6 weeks across the board. The main place you see some disagreement is in how long to use gentamicin for those less susceptible strains. The Dutch and European guidelines say 2 weeks is enough, while the US guidelines recommend keeping the gentamicin going for the full 6 weeks.
Now, here's a really critical concept in modern susceptibility reporting, especially with the European guidelines, the I category. It stands for Susceptible Increased Exposure, and we have to be crystal clear about this. I is not intermediate. It's an actionable instruction for the clinician. When you report an I, you're saying, hey, you can still kill this bug, but you're going to have to maximize the drug exposure to do it. That means higher doses or maybe continuous infusions to make sure the drug level stays above that MIC.
For our pediatric patients, the picture's a little different. A lot of the treatment protocols are actually just borrowed from adult data, with doses adjusted for weight. And the big risk factor here isn't usually degenerative valve disease like in adults, it's congenital heart disease. For prevention and treating milder infections, you see these very specific weight-based dosing recommendations for amoxicillin.
So, what are the actual mechanisms that are driving resistance in Streptococcus gordonii, and how do we define what's susceptible and what's not in the lab?
Well, its resistance is a multi-pronged strategy. First, it has some natural intrinsic tolerance to certain antimicrobial peptides. Then there's the biofilm-mediated resistance, which is a huge reason for treatment failure. The biofilm acts as a physical shield, and it harbors these dormant persister cells that just laugh at antibiotics. And finally, you have acquired resistance, usually through swapping genes in the crowded community of the mouth, which leads to altered penicillin-binding proteins and makes beta-lactams less effective.
And these numbers right here are what we rely on to guide therapy. This table shows the latest EUCAS breakpoints for key antibiotics against Viridin's group strep. For benzyl penicillin, you can see it's a hard cutoff at 0.25. For ceftriaxone, there's that I category we just talked about for MICs between 0.5 and 2, and for vancomycin, the susceptible breakpoint is 2 or less. These numbers are the absolute foundation of our antibiogram.
All right, let's wrap this up by talking about prevention. Since these bacteremias so often start in the mouth, infection control in the dental office is absolutely paramount.
The strategies here are the fundamentals, but they are so critical. It all comes down to strict adherence to standard precautions, obsessive hand hygiene, correct PPE use, and verified instrument sterilization. Managing aerosols with high-volume evacuation is also a big one. And of course, for those high-risk patients, the ones with prosthetic valves or a history of endocarditis, antibiotic prophylaxis before an invasive procedure is still an essential line of defense. So, this all brings us to a final, really important question for you to think about. Given everything we've discussed, how is your institution handling the speciation of Viridin's group strep from sterile sites? Are you still relying mainly on automated systems, or have you made the move to molecular methods for these really critical isolates?
And that wraps up our deep dive into Streptococcus gordonii. If you found this useful for your work in the lab, please make sure you subscribe for more explainers like this one.
You know, we really value the incredible expertise in this community. So please, share your lab's protocols, your experiences, your thoughts, drop them in the comments below. Thanks for joining us.